There's been mixed reaction to the passing of the National Health Insurance Bill by Parliament. The bill will now be referred to the National Council of Provinces for consideration. If it gets the green light, it will then proceed to President Cyril Ramaphosa for possible final approval. Some business leaders and trade unions say the government's plan is unsustainable. Let's get the view of a medical doctor now. Dr. Kgosi Letlape joins us in studio to discuss this. Thank you very much, Doc, for your time this afternoon. Like we said, there's been so much mixed reaction. Let's start with perhaps your overall interpretation and understanding of the NHI bill.
I think it's about time that we start talking about unified health for all, quality health care for all South African citizens. And I welcome it because it begins that discussion. Mm-hmm. So I support a national health system. Mm-hmm. Which means you'd have to fund it from a common pool for all citizens. So I welcome the concept of an NHI. Mm-hmm. But I have serious concerns in terms of the methodology and what is being put out there. The first issue is the fact that for it to be called national, it must be about all of us from the beginning. Sure. It should be all-inclusive. So what is being proposed could best be described as a low-cost national medical scheme. The time for that is past, and that would be a dangerous pathway to go on to. What we need is a national health insurance where the president belongs, where the minister of health belongs, where I belong, where the judge belongs, where all civil servants belong, where all South Africans belong. If it is not for all of us, we have no reason to call it national. And those are the issues that need to be sorted out. There will be other issues about governance. This is probably the single biggest intervention that we would have in terms of rebuilding this country. It's going to be the biggest fund. It cannot be put under the authority of a minister. People that manage that fund, it should be an independent Chapter 9 institution with the members appointed by Parliament with great public participation. Not dissimilar to the way we appointed judges, not dissimilar to the way the board of SABC is appointed, but it has to be independent institution that does not answer to the Minister of Health, who has responsibilities that might be conflicting with the potential functions of the NHI. The minister is a provider of services. So you can't be a provider and also control the fund. And there are other issues in terms of governance. There are other issues that are extremely alarming, where it now has the power to contract with providers. Its duty should be to pay for a defined common package for all citizens. It should contract with every provider out there. It should be a basis of, this is why we pay for these services. All those that are ratified, certified by the relevant statutory bodies to provide that service and are willing to negotiate a price and to charge the price that has been negotiated should participate. It cannot be that somebody is now going to contract. That would have a destructive effect on the livelihoods of the healthcare providers that are out there. Because once you contract, if you're not contracted, what happens to you? I mean, some of us could not stay in public service. We've survived because we've been independent providers in the private sector. If suddenly now someone has to decide whether I get a contract or I don't get a contract, that would be too much power, that would destroy too many lives, that would create too much havoc and disturbance. There are statutory bodies that are out there to certify us for fitness and competence to practice. That should be the license to practice. In fact, citizens should have the right to go to any provider that can provide the care.
Sure. I do think, Doc, we've got from the document that speaks of the payment of healthcare service provider, that's on page 25 of this document. I wonder if we can bring it up for our viewers to also take a look with us. And it reads, the fund, in consultation with the minister, must determine the nature of provider payment mechanisms and adapt additional mechanisms. The fund must ensure that healthcare service providers, health establishments and suppliers properly accredited before they are reimbursed. An accredited primary healthcare service provider or health establishment providing primary healthcare services must be reimbursed by the fund in accordance with the prescribed capitation strategy. In the case of specialist and hospital services, payments must be all-inclusive and 15 based on the performance of the healthcare service provider, health establishment or supplier of health goods, as the case may be. What does that tell you as a health practitioner?
You know, it's overreach. A fund has no capability of accrediting providers. There are independent structures that do that. We have an Office of Health Standards and Compliance. That's the one that should accredit hospitals. We have regulatory bodies like the Nursing Council. It accredits nurses. Health Professions Council. It accredits psychologists. It accredits doctors. That's where the accreditation comes from. The issue of contracting, it should be open contracts to all providers that are prepared to provide the service at the remuneration level that has been negotiated and agreed upon with the fund. You can't make the fund have functions it has no competences for. That would be a calamity in our country. We have proper structures that can accredit different healthcare providers. And those structures should not be marginalized. They should continue doing their duty of fitness to provide services. The fact that I'm an ophthalmologist, it's the duty of the Health Professions Council to accredit me and to register me and to license me to practice. The fact that you have a fund, your duty is to negotiate what my services are worth. And if there's an agreement, I can see the people that you insure. It does not give you the right to accredit whether I can provide those services or not. That is beyond your pay grade. So we should not be creating a monster here. If it's a funding mechanism, that's what it is. It's for payment of services. And when you give it powers like that, we are creating fear, confusion, and you're giving power where the competencies do not rely.
And then it goes further on the payment of healthcare service providers on page 25 again, point 4 saying, without limiting the powers of the minister to make regulations in terms of section 55, the minister may make regulations too, provide that payments may be made on condition that there has been compliance with quality standards of care or the achievement of specialized levels of performance, determine mechanisms for the payment of an individual health worker and 25 healthcare provider, and provide that the whole or any part of a payment is subject to the conditions outlined in a contract and that payments must only be affected by the fund if the conditions have been met. I guess from just an administration or administrative part of it, how much of a task is this? And also, has there been consultation for us to get to a point where there's an entire document that now must sit with the Council of Provinces and then goes to the President?
This is a monumental task that people have never done before. We have structures that have done those issues. There's a statutory body called the Council for Medical Schemes, where certain competencies reside. There are certain things that have been farmed out, where we have medical aids, some of whom have outsourced administration to independent administrators, where that capability lies. When you come up with an issue like that, in a document like that, you're creating a recipe for disaster. You are making things too complicated. If you look at what is being provided in the public sector, you'd have none of those issues. When you're sick, you go there, and they provide you with the services that you need based on the resources that are available. That basically is how a caring healthcare system works. When you now add details of somebody prescribing what should be done, you are creating an administrative burden. And the meager resources that we have will go to administration and not to care. If you look at the current private healthcare system that we have, the administration is too onerous. It takes up too much money. What is being prescribed there is a monster waiting to be unleashed on unsuspecting South Africans. That is something that cannot be done. What you need is a Chapter 9 institution that can rely on the competencies and expertise that we have. You have certain competencies that sit inside the Council for Medical Schemes. None of that is being tapped. It's a statutory body that has been set up, that the minister appoints its registrar. The minister is responsible for that oversight. We now want to go and create a new administrative structure elsewhere that is ill-advised, that is cumbersome, that will be expensive, and you'll be having deployees that have no skills in terms of what they need to do. What we need to do is to harness the expertise that we have, the competences that we have, and harness them for the benefit of all. We don't need 200 odd administrators or a dozen administrators. You need a common Chapter 9 institution that is tasked with the responsibility of managing the fund and being an administrator and collecting the data in terms of the health encounters that go out there.
Sure. Doc, let's just take a look, listen at this, because reaction has been coming through thick and fast. Let's just take a look, listen at what we heard from the South African Medical Association as well.
We've been expecting this because we believe that this bill is being used for electioneering and not necessarily taking into consideration the dire need of South Africans who are in need of healthcare, and changes that are expected, from our government.
What you tend to hear are promises about what this arrangement will achieve. You don't really have any real mechanisms and structures that are coherent to back up any of those objectives that they purport to achieve. So I think that at this point in time, we're not really having a debate on the substance of these proposals, and to a large extent, the parliamentary discussions have avoided dealing with the huge gaps in the technical gaps that exist in these proposals. But while we wait for that debate to happen, we've got a huge problem in that our public health system is failing substantially, and there is no intervention from government to address that.
Doc, in a nutshell, someone went as far as saying that this bill is nothing but electioneering when we take a look that we are almost approaching an election year. But this has got to be about more than that, because we're talking of the lives of people in this country. You mentioned that this could blow up in the face of unsuspecting South Africans. And so what is the call to action?
This is a further fragmentation of our fragmented healthcare system. I don't understand where you have a parliament that now has different healthcare funding mechanisms for its different citizens. We should not forget that the Medical Schemes Act is an act of parliament for funding of healthcare for privileged South Africans. You're now creating a separate act for other South Africans. That's apartheid re-engineered. What should be done is all the inputs should be taken into account. The health market inquiry comments should be taken into account. And what we should be doing is reforming the Medical Schemes Act so that it becomes a national scheme that accommodates all of us, and bringing all those national resources that reside under the Medical Schemes Act. So we are not starting afresh. We are bringing together things that are statutory funds, bringing them together for efficiency, for collective buying power. But what would be rational would be an amendment to the medical schemes, not a new funding mechanism dividing South Africans into different funding mechanisms. So this notion of saying, we've got some reference in the NHI that says, medical aids won't provide what the NHI is providing. That's a battlefield for litigation. If you were bold enough, you should be reforming the medical schemes and allowing those that are not covered by the medical schemes to come into this national pot that has been reformed in terms of all the recommendations of the HMI and all the other things, where we're now creating a benefit structure for South Africans. Not that you earn 10 rands, you are on scheme A. You earn 5 rands, you are on scheme B. Your shortfall is this, your shortfall is this. You can't get this, you can't get that. If we're talking about quality health care for all, we've got to ensure that we break up privilege to be in solidarity with everybody else for a well-defined benefit package for all South Africans that can be accessed from whoever can deliver it in a safe, cost-effective manner.
Dr. Kgosi Letlape, thank you very much, sir, for your time this afternoon.